same platform. So as I discussed, today's class gonna be briefly discussing principles and the management of malignant bone tumors. So as we discussed in the last class, the first class, that it is extremely important to differentiate benign tumors from the malignant ones because the management is entirely different. And in case our diagnosis is not correct and we tend to treat one with the principles of the other, we end up in disasters, and it not only causes issues in saving the limbs, but patients' lives as well. That's why before embarking onto any sort of treatment, planning any sort of treatment, a lot of emphasis is given on correct diagnosis in musculoskeletal oncology. Just a brief part on how we make the correct diagnosis. We discussed it earlier as well. It involves a detailed history and examination where you see the tumor, its size, its location, how many compartments it involved, history of previous surgery, neurovascular deficit, and based upon this clinical examination, you decide whether the limb is salvageable or not. And once you have a clinical history, based on that clinical history, whether you are looking at a benign tumor or an aggressive tumor, you will order those specific imaging investigations. A bit of repeat from the first class. In this, the imaging will also help you to diagnose them correctly. Imaging will tell you the local extent of the disease and distance spread, and that's how we order various investigation. This slide in nutshell talks about the investigations which we do to evaluate malignant bone tumors. Obviously, we need to look at low and then distant metastatic workup as well. So you do standard radiographs, as we discussed earlier, that these should scan full bone in 2 perpendicular planes, including the joints. Same are the principle for doing the investigation of choice for local staging, that is MRI, which has a lot of advantages. For looking at disease in the distance spread in the body, lungs are the most common site, so we do a non-contrast enhanced CT scan and bone scan for looking at skeletal metastasis. Once these investigations are there with you, then you form something called as clinico-radiological diagnosis. But that is not good enough to start any treatment, and you need to do a biopsy and histopathology confirmation of your clinico-radiological diagnosis so that you can start the treatment. And I'm just again repeating it, that irrespective of how typical imaging looks, if you want to start any sort of treatment, whether it is chemotherapy, radiotherapy, or surgery, you must do a biopsy and have histopathological confirmation so that you are not ending up in soup. This we already discussed last time, how the sequence of evaluation of a patient goes, right? Starting from clinical evaluation, taking detailed history examination, importance of doing a lot of imaging before biopsy, and then planning a proper biopsy and then doing it. Just a couple of slides. I'm not going into details, but I thought it will be important because we are discussing treatment, and treatment is actually based on the staging of the disease. We have 2-stage system. The first is AJCC staging system, which is based on the primary tumor, its size, and its spread to the lymph nodes or metastatic sites. Based upon this, we have this classification. Once we have this classification, we plan the treatment, because the staging will let us know regarding the prognosis of the disease as well as what sort of treatment we need to offer. I also mentioned last time that Anakin gave much simpler classification, which is based upon the grade of the tumor, its extent, and any distance spread. All low grades are categorized in stage 1. All high grades are categorized in stage 2. And if patient have any sort of metastasis, it is stage 3. Depending upon extent, if it is only involving one compartment, it is type A. So low grade intracompartmental is type A, and extracompartmental will be type B. Similarly, 2A and 2B for high grade tumors, and any metastasis will be stage 3. As I told you that once you have staging, the two main important questions which patient asks you that what sort of treatment you gonna offer me, and what will be my lifespan or prognosis, whether I'm gonna get cured or not, whether I'm gonna survive or not, depends upon this staging workup. Emphasis on the multidisciplinary management. As you can see in this chart, briefly, I have enumerated that the most common bone sarcomas which you see are osteo, Ewing's, and chondrosarcoma, and even soft tissue sarcoma. You as a surgeon cannot treat them alone. You need help of other colleagues from medical oncology department and radiation oncology department to complete the treatment to have optimal outcome. Hence, we need to form MDT and treat them together. In case you are practicing alone, you need to tie up with your colleagues in the city and form a group. And that's what is the emphasis of multidisciplinary team. And there are a lot of papers which talks about that the management or the treatment given to patients in multidisciplinary team is much better and superior, and there are less faults done in the management of these patients compared to the treatment given in isolated places. And this is the same thing has been updated or talked about in various guidelines like NCCN and Indian Musculoskeletal Oncology guidelines as well. And there are a few papers which talks about the emphasis of the same. So now, when you have a correct diagnosis and staging, then you need to formulate the treatment. Treatment given has to be in particular sequence. As we just discussed, that surgery is not the only modality which is required to cure these patients or to have the optimal outcome. In most of the cases, you have multimodality management. This multimodality management has to be done in a particular sequence, and that sequence vary from case to case, from diagnosis to diagnosis, from stage to stage. That has to be discussed in the multidisciplinary team, and the main guiding principles will be the guidelines which you are following. If you do not have access to the other guidelines, Tata Memorial Hospital and IMSOS Musculoskeletal Oncology Society, they have their guidelines which are available freely on the net, and you can approach them and you can treat your patients accordingly. Most of the malignant bone tumors, they are initially put up on a neoadjuvant treatment, which most of the time is neoadjuvant chemotherapy. And then we need to take care of the local disease. And usually the local control, which is in most of the cases is by surgery, sometimes by definite radiotherapy, is sandwiched between neoadjuvant and adjuvant chemotherapy. Again, emphasis on the same, but now in a bit of detail, I'm going to explain. So 3 most common malignant bone tumors. The first one is osteosarcoma. Surgery is essential for cure, and chemotherapy is must. And I'll show you some slides where we will talk about impact of chemotherapy, giving chemotherapy in improving the survival of osteosarcoma. The role of radiotherapy is pretty limited for osteosarcoma. Usually, it is used for palliation in the pain relief settings only. There is increasing interest of using heavy ion therapy, radiotherapy in osteosarcoma in unresectable sites. And I have a couple of slides later on which I'll discuss with you and explain you those indications as well. Ewing sarcoma is the second tumor which we're going to discuss. And again, like osteosarcoma, chemotherapy is very essential part of of the treatment, and surgery is most oftenly indicated unless and until we have tumors which are unresectable, like for example in the spine or sacrum, or where the resection causes very heavy morbidity. There we can use definitive radiotherapy for having good local control. Now, role of radiotherapy in addition to surgery is much more as compared to osteosarcoma, and we will discuss what are the main indications here. There are a lot of unsolved queries in this aspect, but what is understood is that wherever we have poor necrosis because of less response to neoadjuvant chemotherapy, and if our margins are close or positive, then addition of radiotherapy improves local control in Ewing sarcomas. Then chondrosarcoma, and chondrosarcoma is essentially a surgeon's disease, and we can essentially cure chondrosarcoma if we do good surgical resections, and role of chemotherapy and radiotherapy is absolutely minimal. There's a caveat here. Chondrosarcomas have a few rare types, which includes mesenchymal chondrosarcoma and dedifferentiated chondrosarcoma, which forms about 1 to 2% of all chondrosarcomas. Mesenchymal chondrosarcomas, they get benefited with Ewing's like chemotherapy, and dedifferentiated chondrosarcomas, they get benefited by osteosarcoma like chemotherapy. Now, the prognosis of these two types is pretty poor, and exact benefit, how much we get by giving this chemotherapy, is still a matter of debate. So this is in a nutshell, I spoke to you about how 3 modalities have to be used to treat these malignant bone tumors, and now we'll see them in detail. First, we'll discuss about osteo, and then we'll discuss Ewing's. Now, when we talk about local control, surgery is still the modality of choice, and we use them in most of the tumors. When we talk about surgery, the essential decision is based upon whether we can save somebody's limb or not. There are specific indications for doing limb salvage, but if we cannot do that, then ultimately we need to remove the disease and may require amputation in some circumstances, which in today's era, we have about 10 to 15% of the patients who undergo amputations. Now, when we talk about limb salvage, we must remember that getting a clear oncological margin is must. That's why oncological aspect is always kept at higher level as compared to functional aspect. If your oncological resection is not correct, how beautiful may be your reconstruction, that will fail because you will get a local recurrence very fast. Another point which I would like to highlight here is that in malignant bone tumors, the local recurrences are usually fatal. These are not like soft tissue sarcomas, where having first local recurrence doesn't jeopardize the oncological outcome. But if you have local recurrences in malignant bone tumors, the fatality is more or less sure, unless and until the DFI is pretty long. Hence, we must remember that getting a good oncological clearance is most important in these tumors. If we have decided that in this patient we can do limb salvage, then essentially limb salvage is divided into 2 parts. Number 1 is complete resection of the tumor, and then reconstruction of the remnant defect. There are a lot of indications and contraindications for limb salvage. We will have to discuss them in a different class altogether, but the absolute indication or how we judge is that if the function of a limb salvage limb is inferior to an amputation and external prosthesis, you should not be doing a limb salvage. This is a bottom line which we must remember. When we talk about surgery, and I have been talking about in last few slides, always talking about good oncological margins and complete removal of the disease, it is customary to understand what sort of surgical margins are there. So again, Anneking and Musculoskeletal Tumor Society defined these margins into 4 types. The first one is intralesional. This is where a surgeon opens the shell of the tumor. He goes inside, he does the cleaning of the tumor cavity, and then he fills the cavity with appropriate substances. So this intralesional type of margin is practiced in benign bone tumors, and typical example is how we do extended curettage for giant cell tumors. Then we come to marginal resections, and marginal resection is so as you are seeing in the picture on the right hand side of your screen, you have tumor, and then you have a reactive margin, and then a reactive zone. So if your margin of resection passes through this reactive zone, which is just extracapsular all along the capsule, this is called as marginal resection. This kind of resection is practiced in benign tumors where we are trying to excise them. Why we cannot practice this in malignant bone tumor is that malignant bone tumors are supposed or might have seeding of malignant cells in this reactive zone. So if we are passing through this reactive zone, we might leave some active disease behind, and this may lead to a very high percentage of local recurrence. Typical example of marginal resection for surgeons will be an excision of a lipoma. That is a typical way how we excise it. Then we come to the most common practiced resection, which is a wide surgical resection. This resection excises the tumor, the reactive zone, and a cuff of normal tissue beyond the reactive zone. So you are ensuring completely remove the tumor with a safe margin, and this kind of margin is practiced in most of our limb salvage procedures. Then lastly, we have the radical margins, where the entire compartment is removed wherever there is tumor. So that is radical. I've already explained you this, so I think we can quickly skip through this. And yes, so another important question is that when we are talking about wide margin of resections, that we need to excise these tumors wide, how wide we need to go? This is a question which is again debatable, and all over the globe people have their slight different parameters of defining a wide margin. But if you have to give a ballpark figure, then everybody come to a consensus that when we're talking about resecting a bone, an additional normal area of 2 to 3 centimeter of bone is what is expected as wide margin of resection. Now, what we need to understand is that these concepts were given maybe 2 to 3 decades back. 2 to 3 decades back, our imaging were not that precise. It was not that accurate. And hence, we always used to say that maybe a 3 centimeter margin or a 4 centimeter margin in bony resection is going to be good. Now, with the evolution of precise imaging, we can calculate the disease length very perfectly and accurately. And that what happens in the preoperative planning. Now, with the invent of technology, we also have intraoperative navigation, which can be done by specific machines and instruments. And if we use these techniques, then this resection margin can be brought down to maybe a centimeter or so. But for exam going students, the dictum what we need to remember is a margin of 2 to 3 centimeter of normal bone. This is what should be practiced. And so it was about bone. Now, when we talk about the soft tissue, we need to have a healthy muscle cover on the tumor that is considered as normal. Uh, uh, you must have heard about concept of qualitative and quantitative margin assessment. So a few lines on that. Kawaguchi gave the concept of qualitative margins, where he spoke about various barriers, thick barriers and thin barriers, which are equivalent to 3 or 5 centimeters of margin. So the perineurium or the just a second, perineurium, or when we have perineurium or the sheath around the vessels or sheath around the vessel are considered as fascias which have resistance for tumor spread. Hence, you can be focally close in these areas and your margin of resections will be adequate. And this is what we talk in concepts of barriers given by Kawaguchi. So when we spoke about local control and we saw that surgical resection is the best way to achieve that. This is a typical picture how you excise a tumor and then you get a nice specimen which has a good coat of normal tissue around it, and you can also see the scar of the previous biopsy which was there. It results in defects which are maybe 10, 12, 15 or 20 centimeter in size, and then you need to reconstruct these defects. To reconstruct these defects, we have number of options available, which starts from nowadays very most popular endoprosthetic or megaprosthetic dissections which are available. We also use a lot of biological reconstructions where we use autografts, allografts. Autografts can be vascularized autografts where we anastomose them at the host and the recipient site. And you can use a combination of auto and allografts as well. Most of these reconstruction are done in intercalary type of reconstruction where we have the diaphyseal, we have a gap between the two joints and we reconstruct them with the help of these bone grafts. The use of sterilized tumor bone is getting more and more popular. That is another way of biological reconstruction. And extracorporeal radiotherapy and sterilizing the tumor is pretty common. There are a few more ways how you can sterilize tumor bone. It includes liquid nitrogen, that is the cryotherapy. Some people have also used pasteurization or microwave technique. But at present, globally, extracorporeal radiotherapy is most popular, followed by cryotherapy. Sometimes it is not possible to do conventional limb salvage operations, and there rotation plasty and temporary spacers come handy to give a reasonably good function to our patients. So this is nutshell about reconstruction options. I'm again saying that these are broad principles. This again is one more class in itself. That's why I'm not going into detail, but I'm just giving you an overview what sort of options are available. Now coming to the importance of chemotherapy in the management of malignant bone tumors. This graph is self-explanatory, which talks about improvement of a mere 10 to 15% 5-year survival, which has become now 60 to 65%, and in some Western countries, touching about 75% 5-year survival in the management of malignant bone tumors in pre and post chemotherapy era. And this is what is the importance of chemotherapy, and we need to understand. Hence, we as surgeon cannot treat these tumors alone if you want optimal outcome. You may operate them, but then most of them will end up dying. As I briefly mentioned while describing the sequence of the treatment, usually the local therapy or the surgeries are neoadjuvant and the adjuvant therapy. Neoadjuvant is the therapy which is given prior to the local therapy, and adjuvant is one which is given after complete removal of disease or completing the local therapy. Neoadjuvant chemotherapy have some specific advantages. Now, there are a lot of hypotheses and theories behind it. We exactly don't know how true are these. Few theories says that giving neoadjuvant chemotherapy potentially controls the micrometastasis, which is at the time of the diagnosis, and we can start the treatment early before we wait for the surgery. It may allow a smaller radiation volume if eventually we have to give radiotherapy to these patients. As we discussed, that chemotherapy is pretty effective in these lesions, so they may cause a lot of tumor necrosis, and tumors may shrink a lot, and they may decrease the vascularity of these tumors. Hence, limb salvage is enhanced, or you may be able to do limb salvage in a higher percentage of the patient if you are using neoadjuvant chemotherapy. This line that it provides a window time for customization of prostheses. Actually, about 2 decades back, we were not having prostheses which were ready off the shelf. And we had to order prostheses for each and every patient. And to have that customized prostheses, we use this window of giving neoadjuvant chemotherapy to make those prostheses. I had removed this line few years back, but I have again put it again because now again with the advent of technology, we are doing much complex surgeries, and to reconstruct those complex surgeries, again we need some customized prostheses, and hence again this window can be used again for reconstruction and making those prostheses. One of the most important things which we miss if we do not give neoadjuvant chemotherapy is response, or the histopathological response, or what we call as necrosis happening because of the neoadjuvant chemotherapy. It is one of the most important prognostic markers which helps you to evaluate your patient or guide your patient regarding their prognosis. So if we do not give neoadjuvant chemotherapy, we completely miss on that. But definitely there are a few disadvantages as well. Now, you are giving a chemotherapy in a patient which has high tumor burden. Some of these patients develop drug-resistant cells, and these tumors may increase on chemotherapy or metastasize on chemotherapy, and hence we may lose some patients to this as well. But again, there's a counter argument to it, that if a patient is anyways not responding to chemotherapy, then the biology of the disease is very irrespective. Even if we would have excised these tumors earlier, they would behave the same. And not giving the patients who are not responding properly, then they may have dissemination. This is what is again said. And I already discussed about the risk of local progression and we not performing limb sparing option in these patients as well. Adjuvant chemotherapy is something which is given after the surgery. If we are only looking at giving adjuvant chemotherapy after giving only adjuvant chemotherapy, then advantages can be that you have less tumor volume onto this chemotherapy acts, and you have very less chances of developing a drug-resistant clone. But obviously, we will have a much vascular tumor to operate. We may not be able to do that kind of good surgery in many of our patients. Few patients get micrometastasis, and we are not able to assess the response as well. So these are some disadvantages of using only adjuvant chemotherapy, not a combination. So coming to what sort of chemotherapy regimes are available and what we practice in Tata Memorial Hospital. So I will just open this slide so that you can read it. And now I will explain the kind of regimes available. Osteosarcoma chemotherapy are basically two types: methotrexate based regimes and non-methotrexate based regimes. The regime which you are seeing on your screen is a non-methotrexate based regime, which is a triplet where 3 drugs are used in various combinations. We at Tata Memorial Hospital give 8 cycles. Some institutions complete the same dose in 6 cycles also. Adriamycin and cisplatin, these are the 2 drugs. I'm again repeating, adriamycin and cisplatin are the 2 basic backbone drugs which are to be used in sarcoma. The debate is about adding the 3rd drug. So here we have ifosfamide, which is the 3rd drug, and in methotrexate regime, ifosfamide is not there and methotrexate is there. Now, there is a lot of debate on which regime is better and which is not, but globally we understand that if adequate concentration of methotrexate can be achieved, if high dose methotrexate, which is to the range of 12 gram per meter square, it can be given, which is pretty difficult to give. And you need to admit your patients during all cycles of chemotherapy. You need to hydrate them very well. You need to give them folate rescues. If you can do all that, then the outcomes of methotrexate based regimes are slightly superior to the ifosfamide based triplet regime. The toxicity of ifosfamide is also slightly more. It causes permanent sterilization in male patients, and hence it is not very popular in younger age group. But if you do not have facilities, or if you do not have infrastructure to give proper kind of high dose methotrexate, then please don't attempt it, because giving low dose will be inferior to giving to this combination of which is non-methotrexate based regimes. Just one more line here. There are some institutions in developing countries who practice 2 drug regimes. Now, 2 drug regimes may not be considered as the standard practice, but it is better than giving 3 drug regime where you do not have expertise to take care of toxicities. So if you do not have facilities where toxicities can be managed, please keep adriamycin and cisplatinum as the backbone. Ifosfamide or methotrexate can be used as the 3rd drug. So this is in nutshell about chemotherapy. During your practical exams and in theory, you may be asked about these drugs, their side effects and dosages as well. And this is what typically a new chemotherapy does in case of osteosarcoma. You can see the images on the left-hand side, which are pre-chemotherapy, and on the right-hand side, which is post-chemotherapy, which clearly shows very good ossification and it becomes pretty easy. Now, we have given neoadjuvant chemotherapy. We have excised the specimen. Now, we need to evaluate this specimen. You need to evaluate this specimen for the margins of surgical resection and response to the chemotherapy. And as I told you earlier, that margins of resections are extremely important, because if your margins are close or positive, then chances of local recurrence are extremely high, and local recurrences in bone sarcomas are extremely difficult to salvage. When we look at response to the chemotherapy, then we divide these patients into good responders and poor responders. Any patient who is having more than 90% necrosis on evaluated specimen is considered to be good responder, and anything less than 90% is poor responder. And this slide shows the importance of tumor necrosis, because in poor responders, the overall survival rates are much lesser and local recurrence rates are higher. Now, I will just take a few minutes, and I think I'll discuss a bit. It's okay. So we'll continue for chemotherapy further. We looked at osteosarcoma chemotherapy, and similarly, Ewing sarcoma's local therapy is also sandwiched between induction chemotherapy or neoadjuvant chemotherapy and adjuvant chemotherapy. And hence, I have written here that local therapy may be surgery or it may be radiotherapy. Now, this is a very complex chart which talks about the sequential therapy which is given for Ewing sarcoma. But what we need to remember is that it's a vincristine, cisplatin, doxorubicin, and etoposide-based chemotherapy. In India, most practice something called as EFT 2001 protocol, which was developed in Tata Memorial Hospital in 2001. And it's a pretty robust protocol which is used. This is very similar to Euro-Ewing's protocol, which is available. That is Ewing's 99 protocol, very similar to that. And most of the institutions practice this. Again, we talk about looking at the necrosis of these tumors. Why I am putting these two slides specifically here is that this can be a question in Viva or in theory, which talks about the systems which evaluate the necrosis. For osteosarcoma, the pathologist from Memorial Sloan Kettering, Hughes, gave this classification, and he divided these patients into 4 grades. Grade 1 shows no necrosis. Grade 2 shows 50% to 90% necrosis. Grade 3 shows 90 to 100%, and less than 100%, that is 99%. And grade 4 shows 100% necrosis. So this is the classification which is based on the necrosis which we see after giving neoadjuvant chemotherapy, which talks about response to neoadjuvant chemotherapy. And it is very clear that the patient who have 100% necrosis will have the best survival as compared to the other patients. If we talk about the 2 broad groups, then any patient whose necrosis is more than 90% will have much better prognosis, and these are considered as better responders as compared to any patients who have less than 90% necrosis. Hughes' system was also being used for Ewing sarcoma also. But after about 4 to 5 years, Picci's grading system from Italy came into vogue, and there are head-to-head comparison and studies which talks about evaluation of Ewing sarcoma patient, and it is found that Picci's grading system is more robust, and it is more relevant, and it is more it more relates to the outcome as compared to a Hughes system in Ewing sarcoma. Here, there are no 4 grades, there are only 3 grades. And this doesn't talk about the percentage, it talks about what we see on the histopathology. So grade 1 is if you can see macroscopic viable tumor, that becomes grade 1. If you have few isolated microscopic islands seen, that is grade 2. And if there is complete 100% necrosis and no viable tumor, that is become Picci's grade 3. So this is a more robust system to evaluate Ewing sarcoma, and which is being very popularly used. Now we come to what are the prognostic factors in malignant bone tumors. Metastasis at presentation is single most important prognostic factor. And if we differentiate these metastases, then having isolated pulmonary metastasis or oligometastasis in the lung has better prognosis as compared to nodal or bony or a combination. Size of the tumor. Any tumor more than 8 centimeters have worse prognosis as compared to the tumors which are smaller. Sites where it is difficult to get a wide margin of resection, like pelvis or spine, the outcomes are poor as compared to extremity, where even if you require an amputation, you can get a good surgical margin. We have been discussing about response to the induction chemotherapy in last 8 to 10 slides, and I don't have to elaborate it further. And we've also discussed about having wider margin of resection. That means complete surgical removal is extremely important to have optimal outcomes in these patients. Role of radiotherapy is limited in malignant bone tumors, but I will tell you some specific indications where it is used and will take it further. In the beginning, when I was talking about heavy ion therapies, these were the two main papers which came about 7 to 8 years back, which talks about two Japanese studies. Japanese were the pioneers in using heavy ion therapies for unresectable bone tumors. Now, proton beam therapy and carbon ion therapy are the two modalities which have been used very effectively in the patients where you cannot achieve wide surgical margin, like for example, in the spine or in the sacrum. And these were very encouraging results. And this is after that all unresectable tumors are advised to take these heavy ion therapies whenever possible. In India, there is only one center at present, that is Apollo Chennai, which has proton beam therapy available. Tata Memorial Hospital will have this facility starting in another 6 to 8 months or so. Post-operative therapy has much more finite and defined role in Ewing sarcoma, and there are very specific indications, as I discussed earlier. Getting a very closed or positive margin. If you have planned a positive margin in a focal area, if you could not do wide excision and you just had a marginal surgical resections, if Ewing sarcoma tumor disease volume was more than 300 millis of disease and presence of pathological fracture, these are the indications where we end up giving post-operative radiotherapy in Ewing's sarcoma. And this has shown that it decreases the local recurrence and eventually improves the oncological outcomes. Now, because we are looking at osteosarcoma and Ewing sarcoma, a few words on different varieties of osteosarcomas. Parosteal osteosarcomas are low-grade malignancies, and there is no role of chemotherapy in the management of these patients. We just excise them wide, and that is good enough. Some of these parosteal osteosarcomas may get dedifferentiation. So if you evaluate your specimen and if you get area of dedifferentiation, then these patients will get osteosarcoma chemotherapy. Periosteal osteosarcoma is an intermediate grade osteosarcoma, which is somewhere between parosteal and conventional high grade osteosarcoma. The role of chemotherapy in these patients is not very well defined. The whole globe is divided into two big groups. One group feels that giving chemotherapy will be beneficial for these patients, but other group feels that it doesn't add much value and there's only a little bit marginal effect on these patients and it gives a lot of toxicities. So this is again a matter of great debate in global community, and we do not have the right answer. Maybe one of you may become a good researcher in the years to come and may find some solutions to it. Now, you cannot do any randomized controlled trials on this patient because periosteal osteosarcomas are very rare type of sarcomas. And in Tata Memorial Hospital till now in 2 decades, we have seen only about 30 to 35 periosteal osteosarcomas. So I was talking to you about having your roadmaps ready. So you can take help of NCCN guidelines, you can take help of ESMO guidelines, you can take help of Indian musculoskeletal oncology guidelines and the TMH guidelines. So this is a snapshot of Tata Memorial Hospital guideline, which we created in 2011. Indian musculoskeletal oncology guidelines are also more or less based on the same principles. These are available free on the net and you can access them and can treat your patient with evidence-based medicine. Similarly, we have guidelines for Ewing sarcoma, where we talk about starting them on neoadjuvant therapies, taking a call on what sort of local therapy to be given, having right indications to add chemotherapy later on, or radiotherapy, or a combination, and then how to take the treatment further. Again, we also have on chondrosarcomas, and if you see in the last, we have very clearly mentioned that if you have the dedifferentiated chondrosarcoma, they may benefit or they may receive multi-agent chemotherapy, and in mesenchymal chondrosarcoma, they may receive Ewing's-based chemotherapy. But exact benefit, how much we get from these by addition of these toxic chemotherapy, is still controversial, but these tumors have poor prognosis, and we sort of try to throw everything at them, whatever we can. So thank you so much. That was in nutshell. I'm sorry I took a bit long because I was just explaining a few things in detail. That was in nutshell about the management of malignant bone lesions, where we talk about MDT, where we talk about various kind of therapies to be given, what sort of local therapy works best, how you need to sandwich your local therapy between neoadjuvant and adjuvant chemotherapies, what are the advantages and disadvantages of it, when to do limb salvage and amputations, how to assess your specimens, what sort of information you get, what are the prognostic factors which are help in management. And we also looked at a few different types of varieties of these lesions and the guidelines available. So that's it from my side.